I was very excited about the RESONATE-2 study, and when we set up the trial, we were very concerned about giving a chemotherapy drug to patients who had TP53 mutations. Notably, I've been long held the view that patients with TP53 mutations, or deletion 17p, actually you can make things worse by giving chemotherapy. And the reason for that is that these cells typically are very resistant to chemotherapy. Unfortunately, normal marrow cells are not resistant. So you typically find a situation where you can get the marrow down to reduced to very low levels, but the leukemia cells persist. That's not a good situation to be in, because the major problem that sometimes patients have that leads to the death of a lot of patients is bone marrow failure. And so you're adding that as a possible occurrence that's going to occur more quickly with chemotherapy. So the patients in the RESONATE-2 study were over age 65. We eliminated any patients that had deletion 17p or TP53 mutation, and they had not had prior therapy. One thing that's very important, looking at some of the studies with Ibrutinib, if you have patients who have had prior therapy, that can negatively impact their long-term progression-free survival on this drug. And so if patients have had 2 or more chemotherapy regimens, then they have a significantly shorter progression-free survival than patients who get Ibrutinib with very few previous treatments. So the patients here were treated as the first-line therapy. So this is a very good category of patients without TP53 mutations or having had prior therapy, and they did extremely well. And such that we had, I believe at 36 months, 87% progression-free survival. And now the study has been carried out for going on several years now. And recently we finally finished the final endpoint, but it's amazing that over half the patients could still be on therapy, doing well without disease progression. It's quite a success story. It shows how effective Ibrutinib can be. Of course, with the comparator arm, Chlorambucil, which is the treatment that the patients were given who did not get randomized to receive Ibrutinib, they went on to other therapies, and they were allowed to cross over to Ibrutinib. So we're seeing a survival difference despite the fact that you can cross over, which I think indicates to me that Ibrutinib certainly is far superior to chemotherapy. And I also caution people, because of the fact that chemoimmunotherapy can negatively impact the activity of these targeted therapies, it's a mistake to think that you'll save the targeted therapies if the patients start to fail chemotherapy. It's not a good strategy, because you're actually potentially mitigating the effectiveness of these newer drugs.